Please join me in welcoming our next speaker, the medical oncologist, Professor Steve Ackland. Steve works tirelessly as a clinician, director, research lead, author and editor. And we are so grateful he is here today with us. And please make welcome Professor Steve Ackland.
Thank you. I think this afternoon will be a little bit different to this morning in the sense that we're going to talk about a different aspect of brain tumours, what we know and what we don't know. And I thought I'd start off by telling you why brain tumours are such a hard nut to crack. I remember a long time ago, Mark and Kiralee aren't here anymore, are they? Must have been nearly 10 years ago when MHF was founded. Mark said, "I want to find a cure for brain cancer." And I said, "Oh, okay, that's a fantastic objective to have, but it's likely to be a long, hard road." And that was just an off-the-cuff statement I made. It's turning out to be a long, hard road. And I'm going to sort of introduce you to some of the things that where we've got a little way down that road and other areas where we just don't seem to be cracking it yet. Brain tumours are not unusual in the sense of this sort of behaviour and the resistance that they have to allowing us to understand them and deal with them effectively. Lung cancer was like that. Prostate cancer was like that. 30, 40 years ago, breast cancer was like that. It's through dogged persistence and a lot of good quality scientific observation over many, many years by people all around the world that we now know how to treat some of those diseases better. I'd have to say that we're not really cracking it yet with brain tumours though. So just to give you an idea, I've said no clinical advances in glioblastoma since 2005. This is the front page of the still one of the most important trials that we've ever done in brain tumours, which showed that radiotherapy with temozolomide was better than radiotherapy alone. And that's, what's that, 16, 17, what are we up to, 2022? 17 years ago, right? So we haven't made a major advance in brain tumours, as far as I'm concerned, for 17 years. Not one that impacts on outcome. And I think many of you already know that the outcome for glioblastoma, which is by far the predominant brain tumour in adults, the outcome is dismal. So this is the main take-home message from that 2005 study. It's about overall survival. By the way, don't read the slides because there's too much information on them. They're just there for me to, cue myself to talk to you about things. So with radiotherapy alone after surgery for GBM, at 24 months there were about 10% of people still alive. When you added temozolomide to radiotherapy, it became a bit over 25% at 24 months. And the curve seemed to flatten after 2 years. But this one got to zero at about 5 years, if I remember correctly, in the updated studies. Not a huge study, done all around the world, centred in Europe. But really only 600 patients recruited. Not a lot. There's that many patients in Australia every year. And this is still what we're doing now. We're not doing any better than radiation and temozolomide after surgery for first-line management of patients with glioblastoma. And, this is reality, this curve here. This is what happens with people. So the reason why we're not making progress is, like all things in nature, we don't understand it well enough. Climate change is a good example, Increasing global temperatures is a good example. So we're understanding a little bit more about the molecular landscape of gliomas now, but not enough to crack the big shell and, really make a difference to outcomes. So gliomas develop from a cell which we understand is the astrocyte, which it's a supporting cell in the brain and the spinal cord. It goes one of two ways. If IDH, which is a particular gene, is mutated, then it leads to early tumours, often in young people, the less common type. So astrocytomas, grade 1 or 2, oligodendrogliomas, which is a completely different type of brain tumour where we probably are making some slow inroads into improvements, and 10% of them turn out to be glioblastomas. But these are the unusual 10%. Over on the other side, if IDH is not mutated, in other words, wild type, then there's a whole lot of other named under these headings, molecular changes that seem to occur consistently in some fashion, and we can recognise different appearances down the microscope of those glioblastomas and other types of gliomas that are characteristic. So in the last 10 years or so, we've learned about platelet-derived growth factor receptor alpha, for example, and it's not TRET but TERT. I'm a journal editor. I think the quality of journal publications has gone down considerably in the last 10 years. There are 3 typos on this figure, and the editor didn't pick it up, and nobody in the editor's office picked it up either. So all of these molecular characteristics lead to different appearances down the microscope and probably some different ways in which these tumours grow that we don't yet fully understand. We're learning things about it, but it's not yet put rubber on the road for patients with, for normal people, for people like you and I, for when we or our family members or somebody else we know gets a brain tumour. We'll work on it. Sounds like Hughes having a go at us again. So that's all I wanted to say in relation to things to do with the molecular landscape, except I can give you some complicated pictures to look at, like that one, which perhaps describes how we're now using this sort of molecular information to try and describe brain tumours better. The left 2 images at the top and everything under them relate to oligodendroglioma, which is a fairly rare brain tumour in adults and kids that's treated a bit differently, still with chemo and radiation, but a bit differently to glioblastoma. But if you look at the MR images at the top, you'd struggle to say that this one is significantly different to this one, yet this one belongs to glioblastoma multiforme, by far the most predominant brain tumour in adults. This is what you see under the microscope, and this is under the microscope images of different ways of staining the tissue with antibodies and things so that you can recognise certain changed molecules in those tissues. So histopathology is what you normally see. It's either blue or pink down a microscope, and it's patterns of cells in tissue like this. So you can tell the difference between oligodendroglioma and glioblastoma in some cases. In other cases it might look pretty similar. So then the pathologist nowadays looks at IDH mutation to see if that gives them a clue to whether this is a GBM or some other type of brain cancer, and ATRX changes, which are indicated here, and this particular gene which codes for an enzyme which is involved in the cycle that cells go through, which is called mitosis, the mitosis cycle. And if there's deletion of this one, then the mitosis cycle goes really fast, and it's different and it's bizarre. And that's what tends to occur in some types of glioblastoma, but not in oligodendrogliomas. So this gives you an idea that now, when we go to a path meeting about brain tumours, not only do we get these pink and blue pictures and the pathologist tells us what they think it is, but then we get these other multiple levels of characterisation of the tumour. And I think eventually that's going to lead to improvements in how we manage it. But, just to show you some of the things that have happened in the last 10 years where we try hard to develop new techniques. The Germans are really good at this. The Germans and the Austrians are probably the best at managing research in brain tumours, particularly in adults. In kids it's all around the world, but in adults it tends to be the Germans leading. So lomustine is a very old type of compound, chemotherapy compound. Bevacizumab's other name is Avastin. Some of you might have come across that. It's something that, it's an antibody, that's why it's got MAB on the end, monoclonal antibody. It's a protein that we think does something strange to blood vessels, particularly new blood vessels, and particularly new blood vessels new blood vessels in adults is an uncommon situation, but it occurs around cancers of all types, including glioblastoma. So and bevacizumab does something to edema in the brain. It tends to reduce edema in the brain. So we think it does something to the blood vessels in the brain too, and particularly those blood vessels around a cancer. So this study was designed to see if it would enhance the effect of lomustine against recurrent GBM. In other words, glioblastomas that has recurred in the place where it arose, usually. And what it shows is that the blue line and the red line, there's no difference between the two, really. So bevacizumab didn't enhance the benefits, survival in this case, for patients with recurrent GBM. And it was pretty poor. It was, we've got 8 or 9 months there. It's, if your GBM recurs, you generally don't live long, unfortunately. So back to the drawing boards on how we manage recurrent GBM. Another study that's been done in a smaller number of patients, only 70 you can see here, by a bunch of people from Poland. Don't think we'll have too much research coming out of Poland in the next little while. They'll be focused on their borders. This was a non-randomised propensity match. That means they took the patients who didn't have reoperation and compared them with the ones who did have reoperation and tried to make sure that they were as close as possible in terms of age, gender, time since their primary and various other factors. And so they ended up with only 35 patients. And they propose here that reoperation might actually be helpful in patients whose GBM recurs. In other words, chopping out a little bit more brain and as much, if not all, of the apparent recurrence in the brain cavity. But in order for this to be worth promoting properly around the world, we'd need to do something like a randomised controlled trial, or at least have a much larger study that demonstrated the same sort of benefits. Frankly, right here and now, when a patient with glioblastoma recurs, we talk to the neurosurgeons and we say, do you think you can chop out more of this without damaging the patient? Frequently the answer is yes, in which case they do. And our sense of things, it's non-randomised, it's totally anecdotal, is that people live longer as a consequence and live better. We've not yet analysed that formally. So, as many of you know, the way to improvements in all types of healthcare is through what we call clinical trials, and there's a really good cooperative trials group called COGNO, great name for something to do with the brain, which is run out of Sydney by a collection of people like me and my colleagues in medical oncology, radiation oncology, surgery, palliative care, the sort of psychosocial care that was discussed this morning. And this group for about 15 years has been doing clinical trials, some of which are conducted internationally in order to try and find new ways to manage brain cancer better than we do now. This website, by the way, the web address is there. You can go and look it up anytime you like. If you're not a member, there'll be limitations to what you can see, but you can certainly see some information about all of these and various other studies that have been done through this Australian organisation in the last 10, 12 years or so. And one of the papers they've published is this one, which to me means we're coming from a low base. Got to finish.
I know you got. No. It's not changing over.
Oh, why is that?
I don't know how to fix that.
Where did we get to? No, it isn't, is it?
Slide.
Maybe if I hit the enter button, it'll do. No. That one.
Is there two in there though?
What's that?
If you just scroll down, because I had this issue before.
All right, small adjustment.
Yeah, that's right. It's just a silly system. I don't know why.
It's not a Macintosh. That's the problem. Isn't it?
Yeah, exactly. Which is yours?
It's called GBM22.
So just double click on it and then open it up again.
Okay.
And then go. What slide are you up to? This one?
I'll start there, that'll do.
Oh, well, and just go.
Okay, you've seen that slide. Tell me when we've got to a slide you haven't seen before. That one, that one, that one. Saw that one? Okay. That one? This one? Okay. So this is the one about reoperation. 35 patients that were reoperated and 30 that were in the propensity matched group that didn't have an operation. And it suggests, is all I can say, it suggests that reoperation might be worthwhile. Not randomised. If you don't do a randomised clinical trial, you haven't proven the case most of the time. And Cogno website, the bit at the top is taken straight off their website, and these are the names of some of the studies. Magma, that's a nice one, it reminds you of volcanoes. Lumos is about illuminating our information, but it's also, I can't remember what the LU stands for. Anyway, it stands for things, and when you go onto the website, you'll see what it stands for. Us clinical trialists make up some weird names for our clinical trials that are based on the third letter or the fifth letter or the ninth letter in every second word in the title of the study, for example. PersoMed is about personalised medicine in brain cancer. No rubber on the road there yet, but people in Sydney and Brisbane and Melbourne and various other states of Australia are working on that. And there's several other studies. And the thing I wanted to point out here is that one of the things Australians do, because we don't have a lot of funding and we struggle sometimes, is we go back to basics and we go back to where we're at and why we aren't a step further. And Ben Kong and colleagues from Cogno wrote this a couple of years ago, which describes what's hard about international collaboration in brain tumour research. And so that's probably not a bad paper to read. And I think you can get it. I think it's available on the journal website to the public. But what I was going to say is something that I keep saying in meetings with Mark and Curley and others. We thought we were getting somewhere 10, 15 years ago when the STUP study was published and we'd made significant progress. We thought we'd build on that in 5 years or 3 years or 10 years or something, and we haven't. We started from a low base, we've made some advances, but we haven't got very far yet. That means to us that we need to understand brain tumours much better than we do. The brain is a difficult organism to understand. I find women hard to understand. And every woman is different, and every man is different. And frankly, every brain tumour is different to every other one. And we're learning that about other tumours too. Some of them, they're consistently the same. Prostate cancer in men, for example, there's a limited number of variations of that. So we can treat it in a consistent way and expect results and do one blood test every 3 months and know it's going to work for at least 3-5 years or something. In brain tumours, we're not there yet. We'll keep plugging away with temozolomide and radiotherapy, but we don't know why some people live 2 years and others only live 6 months when we do that. We've still got a lot of work to do, and the only way we'll get there is through research. Some of it will happen in Australia, some of it will happen in Newcastle, a lot of it will happen in overseas. Hopefully we're all talking to each other and learning from each other's experiences and the results of our research and building on that, together with various other players like the pharmaceutical industry, governments, clearly foundations that raise money to support research of all types, including Mark Hughes, and so on. So that's all I wanted to say, and I think I've just opened a whole lot of Pandora's boxes for you to ask questions. Thanks for listening.